Yeah, I'm Mike Clarke. I'm based now in Queen's University in Belfast, where I'm Director of the All-Ireland Hub for Trials Methodology Research, and I've been working in trials and systematic reviews of trials for about 25 years now.
Okay. Would you be able to summarise in 2 to 3 minutes your talk today?
Yeah, what I was asked to do was to talk about a trial or a report of a trial that I felt was particularly influential or I was particularly proud of, and it managed to be both things. It was a trial that was coordinated out of the Radcliffe Infirmary here in Oxford, began about 17 years ago, and it's called the ISAT trial. It's a trial of different ways that you can treat someone who's had a particular type of stroke called a subarachnoid hemorrhage, which happens when a weak spot on the surface of a blood vessel on the brain bursts. Now that it's a very tiny little bleed. It's not flooding the brain or anything. It's a little bleed, so it's going to clot. But what we know is going to happen is that clot's going to give way again. And so what we need to do is try and fix that weak spot. And what happened in the early 1990s is that a new treatment came along called endovascular coiling, where you go inside the blood vessels, you run a little platinum coil up to where the weak spot is, you leave the platinum coil there, and it blocks it from inside. The conventional approach is to sort of go in from outside, lift the skull, rummage around, clamp the weak spot. So you're not closing the vessel off because you need the blood to go through it. You're closing the weak spot off. And so what the neuroradiologists and the neurosurgeons in the Radcliffe Infirmary did is they said, we need to know whether or not there's a difference between these two. And they got people from around the world, many other countries as well, and they randomized the patients. So when a patient came in with a subarachnoid hemorrhage, if they were suitable for either procedure and they agreed to join the study, they were randomized. So that meant we had this fantastic comparison of 1,000 people that were coiled and 1,000 people that were clipped, and you could see what happens to them over the next weeks, months and years. And what it showed is that the group who were coiled did better. They were more likely to survive, they were more likely to be alive and not dependent on the care of others at 12 months, which was the primary outcome of the study. And it went from something like 31% in the neurosurgical group down to 24% in the coiled group. So it's 31% of the people that were treated traditionally, they had unfortunately died or were still dependent on the care of others a year, down to 24% in the coiled group. Published first in 2002, I spoke about the paper from 2005, which was a really robust, longer-term follow-up, and care has transformed for such patients in the future, and it's almost certainly all down to that trial. That trial's got 2,000 patients in it. The rest of the randomized evidence is less than 200. It nailed it, and that's why I'm so proud of that trial, because it said, this is an important question. It went and it answered it, and it was answered by two, what I would call jobbing clinicians here in Oxford. Andy Molyneux, who's a neuroradiologist, Richard Kerr, who's a neurosurgeon. They said, we're going to test this. They'd never done a trial before. We're going to test it, we're going to answer it, and it's great because they actually answered it and transformed care. And we know it's transformed care because we can look now at these sorts of patients being treated across the world, and we've seen that what used to be treated almost always by neurosurgery is now treated almost always by neuroradiological coiling.
Thank you. And do you think the success of this trial comes down to, you've touched on various reasons perhaps why. Is it on the team involved? Is it because the question was something that you could, two comparative interventions that could be tried in such a way? Was it the multi-centre approach to the trial?
It's a multi-centre approach. It was a key question. These coils had only been invented in about 1990. So they were coming in, and what happened was that the clinicians said, let's test them. Let's not just use them. They said, let's test them, because maybe they don't work, maybe they fall out. So there was a genuine uncertainty there. It was then jobbing clinicians who did it, not academic researchers. Academic researchers like myself were involved in advising and so on, but they wanted an answer. They then get the answer, and the community then pays attention to that answer. So everything came together really well and led to what we're always trying to do with a trial, which is get the answer that changes practice. Whatever way it changes practice, that's what you accept. But it changed practice. It said, here is a very clear answer on the difference between the two, and depending on how you value that difference, you can now decide whether or not to use coiling or clipping.
So it's important to pick questions that come from the front line of clinical work.
I think that was one of the really important lessons from this. It didn't come from a bunch of academic researchers looking for a study. It came from practicing clinicians who were saying, well, there is a difference here. And the challenge for them is that two different specialties were comparing their own practice against each other. Neuroradiologists were being compared with neurosurgeons. And that was a tough ask for the neurosurgeons in particular. The neurosurgeons are in charge of these patients. If someone has one of these bleeds and turns up in hospital, they're under the care of the neurosurgeons. The neurosurgeons who joined the trial had to be willing to say, look, I'm not sure whether or not my procedure is the same, better, worse than this other procedure done by one of my colleagues. And they tested that, and those neurosurgeons who took part in that trial, I think society owes them a sort of debt of gratitude. They were willing to test what they'd been doing for years against this new intervention. The new intervention turned out to be better.
Okay. From the medical devices world, we've had different points of view on what to do when a new device is developed.
Yep.
One camp said if there's any doubt, then it shouldn't be on the market or used in practice until the evidence base is sufficient enough to have a clear answer. And the other camp said, well, we need to have things in practice to generate the evidence, and so patients need to be fully informed of the fact that it's in a trial stage or it's not fully established yet. The power of this trial sounds like this may be somewhere in between. Where do you lie?
The power of the trial actually is that in some parts of the UK where a lot of the patients were recruited, they wouldn't use the coils except in the trial. They said, these things, we need to evaluate them. Every patient that receives one outside the context of the trial is a patient lost to the evaluation. So what we're going to do is we're only going to allow the coils to be used if the patient has been randomised to the coils in the context of the ISAT trial. And that also was one of the big successes. It's the best way to do it. If you've got a new intervention and you're not sure if it works or not, evaluate it from day one. That's virtually what was happening with the coils in ISAT. It meant you could recruit quickly large numbers of people. It meant that when you got an answer, people were actually wanting the answer. There was buy-in from the clinical community that said, we need an answer to which is the better of these two things and how different are they, almost from day zero. And that meant that, so it's one of the examples in stroke care where from the introduction of the intervention through to its testing, through to the evidence base being solid, took 10 or 15 years. You'd be hard pushed to find other areas of stroke care, never mind other areas of healthcare, where we've gone from that start to that answer so quickly. And that's exactly what we need to see more of. We need to see the big questions being tackled from early on in randomised trials, giving us the clear answers, and then practice and patients can decide how to use that answer. If they don't have a clear answer, they're just floundering around.